All right, so we're going to talk about the foot and ankle joint today. Um, every time I hear joint, I kind of chuckle, but because this is Las Vegas now. Um, but so we're going to talk about this and go through this. Out of all the joints in the body, the ankle and the foot, wrist and the hand are probably the most complex overall structures we have. There's Jesse. Look, her internet's back up. Yay. Um, but as far as just stuff passing through it, the foot, the ankle, the wrist, and the hand have so many things, so many structures, so many little things passing through it. They are super, super duper complex. And that's why a lot of times with, foot and ankle and wrist and hand, there are specific specialists in PT that deal with each of those just because they're very, very complex. So let's talk about some bones and landmarks before we get going like we have been for how long now, right? So first of all, we're going to have our tibia and our fibula. So we have our tubby tibia and our fine fibula. On our tibia, we have our medial, right, and our lateral condyles. We have our crest, right? The crest is that feeling that you can feel right down the middle of your tibia as you go straight down the middle of it. It's like that ridge. You have your medial malleoli, which is on the inside of the foot, right? Then between the tibia and the fibula, you have this kind of gooey substance. What is this gooey substance in the middle here? So all this stuff here. What's that gooey substance? Yeah, the interosseous membrane, right? So what type of joint is that? Between the tibia and the fibula. You guys remember? It's the joint where it's not a real joint. Anyone? It's a fake joint. Let's see if it comes to anyone. I'm curious to see if you guys remember that from anatomy. Think about it a little bit. Then we have our fibula, right? Our fibula's got our head. Our head is going to be up here close. It's like the pubis symphysis. Good. The head is going to be up here close to the top of your knee, right? And you can actually palpate that. If you reach down and kind of find that lateral condyle, synarthrosis, close. That's okay. I mean, it technically is a diarthrosis, right? Because there's two bones, but they just call it it's a synarthrosis joint. Yep, close enough. Really good. So if you come out here, you find that lateral condyle of your femur, and you drop down from that, you can find that little round head of the fibula, right? It's actually really easy to find. And then that's also where we use a lot of it to find the fibular nerve as well as the head of the actual tibialis anterior. And then at the very bottom down here, we have the ever important lateral malleolus, and that's probably the most important part of the fibula. For the most part, the fibula is a non-weight-bearing bone. It doesn't do much at all. But that lateral malleolus is really, really, really super important for balance. And then we get down here to our feet, and this is where things get complicated, right? So we start with our tarsals. And when I was going through school, I always remembered that the difference between tarsals and carpals, you catch a carp, you walk on tar. That's the way I always remembered it. You guys probably don't even need that, but again, I was stupid in school, and I needed that to remember which was tarsals and which one were carpals. So we have our calcaneus, right? Our calcaneus is the big bone in the back here. That's where the calcaneal tendon is going to attach on to, right? In the calcaneus, we have our calcaneus tuberosity, right, which is where that tendon attaches. And then we also have what's called our sustanaculum tali. What do you think the sustanaculum tali's responsibility for is? If it's a tali, that means it's going to articulate with what? What bone sits on top of the calcaneus? The talus, right? Yeah. right? So that's kind of that ridge that the talus attaches onto or works against. Then we've got our good old talus, right? And you can kind of get on, you can mobilize the talus in people when they're having foot issues. Doesn't feel very good. We have our cuboid, which is on the medial or lateral aspect of the foot, which is the cuboid on. Yeah, cuboid is lateral. That means navicular is our medial aspect, right? And that's going to come into play because we can palpate both of those bones. And then we've got our little buddies that come along with both the cuboid and the navicular. And what are those called? These bones in here. Well, they are our cuneiforms, right? And the cuneiforms are responsible for our posterior foot movement. Some of the key landmarks on here, that navicular tuberosity is really important, as well as this tuberosity out here of the fifth met head or met base, right? And then we have the met head up here. So all of it's kind of important. We can palpate most of the bones in the foot, believe it or not. And does anyone know what's special about the cuboid? What happens to the cuboid quite frequently that makes walking uncomfortable? Not necessarily bone spurs, but does anyone have their cuboid sublux yet? Yeah, it dislocates, right? It truly subluxes is what it does. But it'll drop out inferiorly. And it's not enough to damage the foot, but it's really uncomfortable. And runners get it quite frequently, and soccer players, the basketball players, stuff like that. Where what we'll have to do is what's called a whip mob or a J mob to put that cuboid back in place. Now, technically, that J mob or that whip mob is a grade 5 mobilization, and PTAs are not allowed to do that. So I'm going to preface that when I say that we are not allowed to do that. You're not allowed to do that. And then we've got our metatarsals, right? And we got 5 of them because we have 5 toes. We've got our bases and our heads, right? The base is going to be closer to the foot. The heads are going to be closer to the toes. Then we get out to our phalanges, right? We have our proximal, middle, and distal phalanges. And out here, even if you get out here to that little itsy bitsy toe, even though it may not feel like it, you do have a proximal and distal phalange out there, right? And that middle, but it just feels like kind of gooey. If you actually play with your little toe, there's not much to it. You can't separate out those joints as well as you can the other toes. At least I can't. My toe just kind of smashed up from the martial arts. Yeah, they look crooked, right? My pinky toe is just not existing. It might as well not even be there. But you'll find, amazingly enough, people that have, well, that's the thing is, this is weird, is you would think that the pinky toe would be the choice, but you'll find that people that lose their pinky toe lose a lot of balance. It's amazing how much that lateral aspect of the foot is responsible for balance. I'd probably lose the second one. The second one's not that important if I had to lose a toe. But when we're looking at the metatarsals and the phalanges, most of the weight is bared through the first and the fifth. Second one is the cutest. That's also where they put toe rings and everything, isn't it? I would hasten to say that not a single toe on my foot is pretty, so we're going to go with that. So all our weight's out here and in here. Yeah, I've got hobbit toes. We'll go with that. The reason these toes don't bear a lot of weight is because that's where our arch kind of falls. Put a ring on it. Gotta marry my foot. So when we talk about the aspects of the foot, we're going to talk about the forefoot, the midfoot, and the hindfoot, right? The forefoot is all the way down at the tarsals and metatarsals, or the tarsals, sorry. The metatarsals and the phalanges. The midfoot is going to be our navicular and our cuneiforms. And then our hind foot is going to be our back here where we're talking about the calcaneus and talus. And why that's important is that's going to come into play when we actually do amputations. Some patients will get a forefoot amputation. Some people will get a midfoot. And then if they get the whole foot, they've lost their hind foot. The ankle and the foot perform three main functions. It's shock absorber, right? That's the point of that arch that we have, right? So that as it comes down, it can collapse and absorb shock as we walk. Adaptation to the ground level, right? And this can be both good and bad because we've taken as a species to wearing shoes. So we've lost a little bit of our proprioception on ground. But all it takes to know if you're adapting to ground is for you to go downstairs once and miss a single stair. And you'll suddenly know how important that foot is to telling you where things are. And they provide a base support for propelling the body forward. They're important for walking. So the motions we have, well, we have ankle plantar flexion, dorsiflexion. I always thought it was weird that they're plantar flexion, dorsiflexion. Why can't they just call it flexion extension? I mean, that would have made our lives so much easier. But instead, we call it plantar flexion, dorsiflexion. But if we were talking about flexion and extension, which one of those would coordinate with extension, where it's moving away from the body? Would it be plantar flexion or would it be dorsiflexion? Yeah, plantar. Plantar would officially be our extension. That means dorsiflexion is our true flexion motion because it's pulling back towards the body. But we got plantar and dorsiflexion. And I don't know why plantar flexion is separated and dorsiflexion is not separated. Weird rules in anatomy. I'm just going to go with it. Then we got in and eversion. There is some ab and abduction we'll talk about. There's a really small amount of supination and pronation. In the foot, though, supination and pronation is a combination of plantar flexion, inversion, and adduction, whereas pronation is dorsiflexion, eversion, abduction. And I know that you guys are going to go, well, we didn't cover ab and adduction of the foot in anatomy. Well, that's because we rarely ever talk about it. So here's dorsiflexion, plantar flexion, inversion, eversion. So this is when we're talking about ab and adduction. It's just the turn of the foot. Excuse me. Ugh, I told you that energy is gone. But really, when we're talking about ab and adduction, we're really talking about what's happening more at the hip than the foot. Because if you stabilize the foot, it's really hard to turn that foot in and out, or stabilize the hip. It's really hard to turn that foot in and out like that's showing, right? So one of the key things we have to find when we're working with patients, especially that have feet problems, is what's called subtalar neutral. And that's kind of where we want that tibia, the talus, and the calcaneus to all be in a very, very, very nice, neat line, just like it is here, right? So that way, that vertical gravity line that's going down through the leg passes just between all of that, right? Let me get the arrow out because the arrow would be better. So that that vertical gravity line falls exactly like that. Remember when I talked about varus and valgus, and I said that typically the ankle is going to follow the knee. So if you have genu valgus, typically you're going to have calcaneal valgus. But again, that can be weird. It can change on you. So here we have one that's calcaneal valgus, right? The weight comes down like this, and then it kind of angles in. That's going to affect weight bearing. That's also going to affect the stability of the ankle. Either of these kind of will affect your stability of the ankle and the position that your foot strikes the ground. But when you're looking at this, calcaneal valgus, the calcaneus is going towards the fibula. Calcaneal varus, the calcaneus is going towards the tibia or the medial malleolus. If you see that, that's the way I always remembered that. But again, like I said, as long as for most part you remember that it goes with the knee, you should be okay. Yep, so calcaneal, let me get my little arrows back up here. So calcaneal valgus goes tibial, or fibular, I'm sorry. So it goes out here towards that fibular head. Calcaneal varus, oops, that wasn't an arrow I needed, goes in towards our medial malleolus. But again, which is more common? Typically the valgus, which puts us more in a pronated state. But it just depends upon the knee. Everyone's a little different when it comes to the knee, and it depends upon sports too, because some positions in sports will lead you to one or the other. When you think about the stance for you, Dylan, think of a stance a catcher's in, right? That's going to definitely lean more towards a pronated state at the foot, just because of the way the knees are planted and they're worried about the ball coming in and stuff like that. So it's going to depend upon a lot of what the patient does on a daily basis or doesn't do. But in the end, when we are actually working with the foot, we're actually going to try to manipulate that calcaneus just a little bit and have them in standing to get them into subtalar neutral, so they can feel what it should feel like. So this is not a structural deformity per se. A lot of times this is just a shifted bone. When it becomes structural deformity, unfortunately, there's nothing we can do about it. The only thing we can do is compensate for it. But for the most part, it's usually just a shift in the bone itself. So at the ankle, we have a couple of different joints. We have the talotibial, right? That's where the talus is articulating with the tibia. We have the subtalar joint, right, which is below the talus, and that means it's the talus articulating with the calcaneus. And then we have our transverse tarsal joint, which helps make up our arch of the foot. So talotibial is uniaxial and triplanar. The main job of talotibial is plantar flexion, dorsiflexion, right? Kind of goes right through those malleoli and allows us to plant down and come back up. That's kind of looking at it from the front side and this lateral aspect, right? So with this, right, you're typically going to have some rotation and some glide, right? So depending upon which way we're going, if we're going into dorsiflexion, there's going to be a posterior glide, right, and allow it to kind of move nice and smoothly. If we're going to plantar flexion, there's going to be an anterior glide. There's not a lot of spin. There's not a lot of, locking in mechanisms. It's just a pure glide of that superior aspect of the talus on the inferior aspect of the tibia. Both of those structures have a really, really, really nice thick layer of articular cartilage. And that thick layer of articular cartilage allows them to glide really nice and smooth. Now you get little micro tears in that cartilage, and it can really kind of hitch up your ankle plantar flexion, dorsiflexion. And if you have a patient that has it, a lot of times they'll say that. It says, well, when I'm in like really hard pointing my toes down, I get a little bit of hitching going on. And you can kind of feel it if you get on palpating on them. When they plantar flex, if they've got some of that cartilage torn up, it'll feel like a speed bump in the road. And it doesn't feel comfortable to patients. It's usually non-painful. It just kind of feels like the bones kind of clicking as they're moving through it. Here's that subtalar joint, right, underneath the talus. So it's this area here. Its primary job is inversion and eversion of the foot. So it allows us to turn our foot in and turn our foot out. A lot of times what we're going to find with most of our patients, and probably with most of you, is you'll have fairly decent inversion, but you may not have a lot of eversion. And that's kind of common. You don't have as much eversion as you have inversion, right? And then depending upon your structural deformities, you may have a lot of inversion and almost none. Like I've got about 5 degrees of eversion, and that's definitely not normal. I can stand on the lateral borders of my feet, but I can barely get into eversion. Then we have our transverse tarsal joint, right? So transverse meaning going across the tarsals. It works with inversion and adds a combination of supination, plantar flexion, and adduction. We have some eversion going on there as well, which is pronation, dorsiflexion, and abduction. Good news. You have to know that this transverse tarsal exists. You have to know that it has a little bit to do with inversion and eversion, but your board questions are not going to get that specific, having you know what the combinations are of it. So that's the bonus point there. And again, if you're going to work on the foot, this is one of the things you're going to know pretty heavily. The main thing you need to know is that that transverse tarsal joint is where primarily the cuboid and the navicular articulate with the talus and the calcaneus. And then we go out to our MTP joints, right? Metatarsal phalangeal joints. That's where those metatarsals start coming into those phalangeals. The greatest range of motion, right? That was good. Range of motion. Range of motion is in the first big toe. And that kind of makes sense. You can actually feel that in your foot, that you actually have the most function in that big toe, right? You can use that big toe to pick up stuff if you work at it good enough. And then you've got your pips and your dips, right? But the main thing at your big toe is just like your thumb. You've only got an ip. You don't have a pip and a dip because you've only got those two bones in the actual big toe. So foot motion, we talked about MTP, right? We have flexion, extension, hyperextension, ab and adduction. So you can spread your toes apart. Does anyone know what term they use in the hospital a lot for spreading your toes apart that they don't usually use for the hands? Okay, it's part of Babinski. Good, you're right. They call it splaying, S-P-L-A-Y, right? Splaying is where the toes kind of fan. And that's a positive Babinski reflex. You're right. That's exactly what it is. So if the toes as an adult kind of splay and you can't move your toes, good. That probably means you don't have a positive Babinski. That's a good sign. Right? Positive Babinski is a bad thing. When should the Babinski reflex be integrated in a child? What's the max time frame? Should be integrated by 6 months, but what's the oldest it can be? Does anyone know? Has to be integrated by 24 months. If it's not integrated by 2 years, the child probably won't walk. Because you need to be able to have that Babinski integrated so that the toes don't go weird every time you plant down. So 24 months is kind of the latest. Now, typically 6 months is when it's integrated by. But that just shows you, the stuff that you learned in what do you call it? Growth and development, that it's normally integrated by this time, but there are some time frames that in pediatrics, so we go, okay, yeah, I know it should be integrated by now, but we have some wiggle room there on when it can get integrated by, right? There's our flexion, extension, hyperextension. Again, extension of the toes is just return to 0. Hyperextension is when we pull back, right? And that allows us for push off when we're walking. And here's our kind of ab and adduction. Doesn't work out as well. All right, here's where things get complicated, because this is when we start talking about the ligaments of the ankle. I'm going to warn you, this is probably the hardest part of this lecture. We have our deltoid ligament and we have our lateral ligament that primarily make up our compartment of the joint capsule, right? What makes up the arches is the medial longitudinal arch and the lateral longitudinal arch. When I was studying for this, what I remembered was there was one longitudinal. Yeah, that was good. One longitudinal arch. It was both medial and lateral, and it made up the arch. There's also the transverse arch as well. So we're going to look at those here. So here's our medial joint capsule, right? The medial joint capsule is made up of the deltoid ligament, right? So the deltoid ligament has 4 specific parts. The good news about the deltoid ligaments and its parts, for the most part, they are named for where they start and where they go to, just like the hip is, right? So you have your posterior tibio-talar ligament. It's on the back side of the foot, and it goes from the tibia to the talus. Typically, if you see something that's a tibio something, you're going to be talking medial aspect of the foot. So if I say that I have a tear in my tibiocalcaneal ligament, did my foot go into inversion or eversion? Okay, so I got 2 inversions. Do I have any eversions yet? Okay, so I got an eversion. So let's think about it. If I roll into eversion or inversion, right? So if I turn my foot in, here's my ligaments. What's happening to my ligaments? Oh, good. You changed your mind. Good. Right? Because if I go into inversion, those ligaments are shortening. So I didn't put a shoe on today. And so I put shorts on so that we can kind of use my foot as an example. I'm a great exemplar. So when I go into inversion, that shortens, right? This will shorten up just a little bit. It'll just take in, that foot's kind of turning like that. But when I go into eversion and my foot goes like that, now that ligament's going to lengthen out. And that can lead to my tear. The good news is we don't usually do eversion sprains. It's pretty rare, right? But that's the kind of question you might get is, it might ask you, your patient has torn their tibial calcaneal ligament. What motion is likely to have caused this? And you have to think, well, tibio calcaneal means it's on the medial side. So that means their foot went to the lateral aspect. That's kind of the thought process when you get questions on these ligaments. You have anterior tibio-talar. If you have posterior, you're usually going to have an anterior. You have your tibial navicular. And then the one a lot of people talk about is this one right here, your spring ligament. Why do you think that spring ligament is important? What do you think it helps us with? Yeah, bounce. Good, right? It helps with the bounce and it helps us with toe off. So that's kind of important to our overall function of our foot, right? And that's one that, if you're going to tear on the medial aspect of the foot, that's kind of one that's used. It's common that you're going to tear. Then we go out to the lateral complex, and if you look, most of the stuff on the lateral aspect of the foot are fibular, and that makes kind of sense, right? So we have primarily three parts. We have the posterior talofibular, anterior talofibular, right? And then at the bottom, we have our calcaneofibular ligament, right? Those are the kind of three parts of that lateral joint capsule that come together and form almost a cruciate ligament. They're not considered a cruciate ligament, but they almost form a cruciate ligament, like in the knee. Now, there are two other ligaments up here that are not part of that joint capsule because they're above the ankle, right? But those two ligaments, the anterior and posterior, what do you think they're going to be named for? Because they're going to go from the tibia, the tib-fib ligaments. Good, right? So their job is just to hold those two bones together. There's not really, it's not an ankle support joint at that point. It's just kind of holding them together. But these three are your primary lateral joint capsules. Now, those, on the other hand, unfortunately get torn quite frequently, especially that inferior one down here, because when you roll your ankle, a lot of times you stretch that one. And if you're going to roll your ankle, you're usually going to roll it into inversion. So then here we go. We look at some other parts of the foot, right? What we're looking at here's our main weight-bearing surfaces. So we have our first metatarsal, fifth metatarsal, and then our calcaneus. That kind of forms our triangle of weight-bearing. And that's going to kind of tell us if we have somebody that's walking normally or abnormally by looking at how they're weight-bearing on their foot. Here's our arches, right? We have our longitudinal arches, our medial and lateral longitudinal arches, and then we have our transverse arch. All of those are going to be responsible for pulling that foot upwards and allowing us to have that natural arch to our foot. There's our transverse arch. Now, with the transverse arch, what you should know about that is the transverse arch goes from cuboid to first cuneiform. That's really what you need to know about it. It's primarily responsible for giving us our nice arch of our foot, but it goes from cuboid to first cuneiform. So then here comes the one that kind of bugs a lot of people, right? Our plantar ligaments. Because a lot of people get, what do people get common in their foot that might involve these ligaments? Plantar fasciitis, yes, right? And if you've never had plantar fasciitis, I applaud you. Please don't ever get it. Yeah, it is the most probably irritable disorder you can get. It's not a lot of pain, it just is purely irritant. Yeah, exactly, right? And it's amazing. It can knock out major league players like that. And you're like, wow, this is just his foot hurts. But when you think of what you do with your feet, it kind of definitely comes into play, right? So we talked about our spring ligament already. Here's our long plantar ligament. Guess what? It's on the plantar surface and it's long. We have our short plantar ligament, right? And then we've got our plantar fascia. That's kind of the important part. That plantar fascia is where we get a lot of plantar fasciitis. The season ending, right? Yeah. What is the job again of fascia in the body? You guys remember what the job of fascia is? Holds things together, connects, and allows for a gliding surface, right? So this fascia down here allows to keep that skin kind of gliding along and kind of protect those muscles underneath. There's a layer of fascia on the muscles themselves to keep them from sticking to the bones. When you look at your body, you're going to have multiple layers of fascia between different layers. And the job of the fascia is to hold everything kind of tight together and keep everything gliding. So a lot of times when you get this plantar fascia, what happens at plantar fasciitis is somewhere in here, you get a hitch in that plantar fascia and it just gets stuck down to stuff. And so then instead of having a normal glide of this fascia, this part back here is gliding, this part up here is gliding, but this is just getting stuck. And when that gets stuck like that, pain ensues. So here's kind of looking at that plantar fascia from the underside and the top side of the foot, right? There's a lot of stuff that goes on to this. But that plantar fascia kind of lays over all of those ligaments and allows us to keep everything nice and smooth. But if you look at the size of that plantar fascia, man, that's not a tiny piece of fascia. Yeah, it's like getting knots. Exactly. That's a good way of looking at it. I often think that it's that you almost get potholes in your fascia. And the potholes get stuck, and the only way we can do it is by filling in that pothole by breaking it up. But a lot of times when they have this plantar fascia, the best thing we can do for it is aggressively tear at it. And I'll say that if you ever have really bad plantar fascia and you get somebody that actually works at it, it's a combination of, oh my God, that feels good, and oh my God, please, I'm going to murder you, because it hurts that bad, but it hurts that good as well. So you're responsible for knowing the origins, actions, and assertions of each of the following muscles. Well, all of them, right? So you have to know the gastroc soleus plantaris, tibialis post, flexor hallucis, and flexor digitorum. These are the primary muscles you're going to have questions on when you're talking the boards, right? Here's our gastroc and our soleus. What's special about that soleus muscle? Does anyone know? We'll talk about that in a bit, Eric, actually. So hold that question for just a few minutes. What's special about that soleus muscle? Did you guys learn about that? The soleus itself is the strongest muscle by volume in the body. And that kind of makes sense. Think of what the soleus is responsible for. The soleus is responsible for helping us to plantar flex when our knees are bent. And if you have your knees bent and you're kind of in a squat, you can still come up on your toes. That's all soleus. To me, that's amazing that that little muscle down there is responsible for lifting your whole body, right? That's really, to me, that's cool. Right now we have our gastrocs that help us most of the time. The gastroc heads are designed to be big because of, planning and walking and stuff like that. Then we've got our plantaris, right? Here's our posterior group, tibialis post, the flexor group, all come posterior. Yeah, that is, yeah, you can hold that position. Thank you, Renee. There's one more reason I don't need to do yoga. Somebody told me once, you may not be able to do yoga, but why don't you do hot yoga? Have you guys felt the way I keep my office? There's no way I'm doing hot yoga. So our flexors are part of our posterior group that allow us to flex the foot, right? Our anterior group is going to be primarily our tibialis anterior and our extensor groups. And then our lateral group is going to be our peroneal group or our fibular group. So here's kind of looking at our anterior group. There's tibialis anterior, which is our big muscle on the front. We have our extensor hallucis longus and our extensor digitorum longus. Again, anytime that you hear a longest muscle, it's going out to that DIP. There's our peroneal longus, brevis, and tertius. And probably out of all of the things, that peroneus tertius is the hardest one to find. A lot of times it's really easy to find longus and brevis, but that tertius is just in a really weird position, and it's often hard to find if the patient's got problems with it, right? But this peroneus longus is really easy to find because a lot of times you'll hit that inadvertently when you're doing E-stim on your tibialis anterior, because your tibialis anterior kind of lays here, right? If you go back to this previous slide here, go back, there we are. There's that tibialis anterior, so it kind of lays over it. So that's why a lot of times when you want to do that E-stim on that tibialis anterior, and you're laying down your pads, you want to try to make sure you stay a little bit away from that fibular bone if possible, because that'll keep you more off that fibular muscle and more on tibialis anterior. Because how will you know if you've got peroneal group instead of tibialis anterior? What will the foot do instead of dorsiflex? So if peroneus longus pulls here, it's going to do what to the foot? Yeah, it's going to evert, right? Now, sometimes when you're doing E-stim on that foot, you might start getting a little eversion at first, and then it pulls up. Did anyone experience that when you guys were doing Russian at all? Yeah, that's okay. That just means that you have a little bit of bias towards that peroneal group. You just kind of have to just deal with getting through that eversion to get to the dorsiflexion. It happens. But if all you're getting is eversion and no dorsiflexion, you're on the wrong part of the muscle. So that's kind of a really important key when you're dealing with the E-stim of that lower leg area. It actually comes into play when we talk to the hand then as well. And then we have our intrinsic muscles. Oh no, what are the difference between intrinsic and extrinsic muscles again? Yes, they're inside, right? Intrinsic means they are in the foot. Extrinsic means the muscle body itself is outside the foot. I was just in here thinking all this caffeine I'm drinking. I wonder if I'm allowed to have this. Should have read my post-op instructions. Just a thought. So they consist of 4 distinct layers. Most are on the plantar surface, and then the deepest layer consists of the dorsal and plantar interossei. If you had to guess right now, and I asked you, could you please point? Because I can't function without it. I'm addicted. This is better. I've only had 1 cup of coffee today, so I'm doing a lot better than normal. I've had 5 glasses of water too, so that's important because I was really dehydrated. So if I had to ask you, back to my point, if I had to ask you to point to your dorsal interossei, could you find it? What do you think? Well, let's think about it, right? I'm going to see if I can put my foot up here where I can see it. Oh, no. There we go. Dorsal is going to be on the dorsum of the foot. Interossei is going to be between the bones. So your dorsal interossei are on the top of your foot between your bones. It's really that simple. That means your plantar interossei are going to be where? on the bottom of the foot, and then between the bones. And on the bottom of the foot's where a lot of you're going to have those lumbricals as well. So here's kind of looking at them. There's our plantar fascia kind of cut away. So there's our lumbricals, right? The lumbricals kind of lay over and they allow us to actually, again, in the hand, they'll allow us to make the duck grip. In the foot, they allow us to kind of pick stuff up. There is this other muscle called the quadratus plantae. What I'll tell you about that is no one cares. Actually, you just have to know it's in the foot. That's it. But you're not going to get a question about what does the quadratus plantae do? Well, its job is mainly to help with that arch of the foot. But all of these muscles over here on the left side, this abductor, this flexor, this abductor here, all of those are extrinsic, right, muscles. And we get down here and we have the intrinsics. So we keep moving. There's going to be, or should have our interossei. Where's my interossei? Oh, there's our interossei, right? We have all these little muscles up here between the bones. There's our little plantar interossei dorsal. I always love the look of the interossei. They look like feathers to me. Aren't they cool? To me, they just look cool. And in the hand, you have the same interossei. You have palmar and volar interossei. So there's kind of what they do. They help with all that. So common pathologies. Let's talk about a different type of pathologies that we're going to, because this comes into play when you're talking about plantar fasciitis. Shin splits or medial tibial stress syndrome, MTSS. Who get shin splints? What type of people? Runners primarily, right? But also around here, servers. Right? People that are in the service industry get shin splints quite frequently, actually. Just from literally, when you look at them at the casinos and stuff, they're running back and forth, delivering drinks and working those tips, right? What can we do to help with MTSS? What kind of treatments have you learned about for that? Ice massage, good. Massage, good. And what form of ultrasound do you think you'd do for it? You're not going to want to heat it up. Yeah, superficial, good. Superficial and pulsed, good, right? Because we're trying to heal it. I liked ALXed. That's a new one for me. I like ALXed. Pes cavus and pes planus is literally what? Does anyone know? Pes meaning what? Foot, good. Cavus and planus meaning what? Yes, caving means you have too much of an arch. Planus means you have a flat foot. Good. You have Hallux Valgus. Oh boy, Hallux Valgus, where the distal end is pointed laterally. Does anyone know what Hallux Valgus can lead to eventually? On the big toe that a lot of people get. Yes, bunions. Good. Right? Hammer toes. Hammer toes are where you end up with PIP, so proximal interphalangeal flexion, and distal interphalangeal extension. So you end up a point where this part's flexed, but that part's extended. Don't know if you can see that. So it kind of looks like that on your toes. So your toes are constantly stuck like that. That's really going to affect your overall plant and push off if your toes are all like that. Turf toe. Oh, I always hear about soccer players and football players getting this, right? What is turf toe? Does anyone know what turf toe actually is? I guess you can guess where you get it at. Primarily from playing on what type of surface? Yeah, AstroTurf, specifically, right? Now you can get it from playing on grass too, so it's not only just, yes, it's super hyperextension of the big toe, exactly. And so when you do that, you've kind of stretched and almost torn out all those ligaments holding that toe together. And it's really painful. A lot of them will lose motion in their big toe from it, right? It can be either hyperextension or it can also be flexion as well, like extreme, extreme, extreme flexion. Ankle sprains, probably the most annoying next to plantar fasciitis that you can get in the foot. And again, if you are talking about an ankle sprain, you are most likely to sprain the ankle into which position again? Inversion. Good, right? If nothing else, if you get nothing else out of this lecture, because that's a question they love to ask on the boards, is what position is the most common for ankle sprain? It's an inversion sprain. Ankle fractures, bimalleolar and trimalleolar are common fractures you have there. And you're like, well, wait a minute, we don't have three malleoli. Well, three malleoli talk about the actual fracturing of the actual malleoli off the ankle, and then also a fracturing of the talus. A lot of times your ankle fractures are going to happen into car accidents. Why might you break your ankle in a car accident? Yeah, you slam on the brakes and you got that foot locked in, and then you get that impact. That force has to go somewhere, and a lot of times you end up with a trimal fracture. I'll have to see. I might on this computer have my friend's trimalleolar fracture to show you. I'll have to see if I have it. He's a big guy, and he had a nasty trimal fracture. And now he has something like 32 pins and rods in his ankle. So here's MTSS, right? This is where we get inflammation of the anterior tibia. Can also be inflammation of this nice interosseous membrane as well, so you got to pay attention to that. The damage is occurring to the bone and must be treated with rest. This is contrary to almost every coach's advice, because almost every coach, when you have shin splints, will tell you, run through it. Walk it off, right? You cannot walk off shin splints. The only thing you're doing is making it worse. And that's why a lot of athletes that get shin splints get them as recurring problems, because they don't rest. And in order to allow it to heal properly, you have to let those splints rest. If you don't, it will keep coming and keep coming. It is muscles going over the tibia. Like I said, the problem occurs, so we call it MTSS. This is the problem here. We have a little bit of a misnomer, okay? We call it MTSS, but what it is the bone being pulled, whether it's tibialis anterior, tibialis posterior, your fibularis group, or this interosseous membrane. Crucial ibuprofen. Huh. Never heard of that. Not sure how that would work. But that's interesting. I mean, it's not any different than Goody's headache powder, so that's a unique treatment. I have to look that up. I've never actually heard that. Probably is a placebo. Then they just say, okay, we got this good stuff on, you get back out to running. But you've got to think, so what's happening here is, as you're running, you've got all these muscles kind of laying over these bones, right? So this one goes down here. And we got this here. Here's our big tibialis anterior, right? As those muscles are causing this foot to go up and go down and go up and go down, they're pulling on this surface of the bone, this surface of the bone, this surface of the bone. And the more and more it pulls, it's just taking little layers and chips off of that bone, right? Same thing can happen again, like I said, in the middle here, in the interosseous membrane, because the job of this interosseous membrane is to keep those bones in contact with each other. Well, as these bones are rotating and moving, they're pulling apart, and so you can end up with a little bit on the inside here as well. But the key thing here, if you take nothing else out of this part of it, is the only real way you're going to treat shin splints is rest. There's nothing you can truly, I mean, ice massage will help. It will relieve the pain. It'll cut down on the inflammation, but they've got to rest their leg. Here's pes cavus versus pes planus. And you definitely can see on this one that's pes cavus over here, that is an abnormal arch. And that is not a doctored picture. All right? And then pes planus, you definitely can see they are definitely planted on that whole foot. There's no arch to that foot whatsoever. I don't know if it is now, but it used to be if you had flat feet, you were not admitted into the military. I don't know if that's still a requirement, that they would not let you into the military with a flat foot because they wanted to give you flat feet while you're in there. Again, it's kind of like the knees. Yeah, no, I didn't think so, but it used to be. That used to be a hardcore weird thing, right? Show was getting what do you call it? Bone spurs that you get out of going to Vietnam. Oh wait, did I say that? I love this picture because this is usually the part where somebody vomits. So this is Hallux Valgus. You can see his zombie foot. Can you see that's not supposed to be the way that it's working? I hope you can see that. Right? And you can see the bunion developing, right? Can you guys see that? So the only thing they're going to be able to do for this is what? What do you think they're going to have to do for this? Well, not necessarily chop it off. They can put a spacer in here. So they can put a spacer in here to kind of force it out, and then they're going to do surgery. Yeah, holy water. You know how you make holy water, right? You guys know how to make holy water? You boil the hell out of it. It's a good old Catholic joke. I actually had a priest teach me that when I used to go to church. Here's hammer toes. That's your problem right there. And again, this guy's got a little bit of Hallux Valgus too. You can see in this, the left foot, they've got some valgus going on in that toe too. This poor person. Sounds like a super bad hearing. All right, so thank you for letting us know that lab is canceled. Yeah, she just emailed me as well, so. Turf toe. There's where that first metatarsal joint gets kind of jammed up. And again, the problem with that is, just like most injuries to the foot, it's a chronic injury. Once you get it, you kind of keep getting it. It's almost like the ones that get high ankle sprains again. People that get high ankle sprains, they consistently get high ankle sprains. So this is the problem with the foot is, once you've kind of injured the foot, you set yourself up for re-injury. And if you look at athletes like Pujols and, like in my case with Atlanta, with Julio Jones constantly has turf toe. So much so that they tape his foot so that he doesn't get it. There's an ankle sprain. That looks comfortable. So what type of an ankle sprain is this? Yeah, the ankle is very similar. And that's the thing. Here's the deal. A lot of times, it's a bad one. That's an inversion sprain. A lot of times with ankle sprains, they're going to lead to low back problems. Why do you think that is? Or foot and ankle? Yeah, you're going to start favoring. Exactly. So you start worrying about that one foot that you know that is bad, and then you start compensating while you're walking, and you transfer all that force up to your knees and your back. And then you end up with low back pain. Right? So keeping your ankles nice and strong is kind of important. Right? That's actually really good for your health, and it helps you, I mean, it helps you with running, helps you with everything if you can do that. I don't always, you know, and somebody says, because I have I'm constantly inverting, spraining my left ankle. And they're like, well, why don't you wear an ankle brace? Because an ankle brace would prevent me from inverting constantly. But again, I'm of the belief that as soon as I put that ankle brace on long term, I'm actually weakening the ankle because I'm going to start relying on the brace and less relying on the muscles of my foot. Here's the bimalleolar and trimalleolar fracture. That looks kind of painful, right? So bimalleolar, we're going to have the fractures out here on the sides. And then trimalleolar, you can see you've got that kind of inside malleolus that gets fractured as well. These fractures are extremely painful. And the only way they're going to fix this, let's clear all that and get a different color, is we're going to come in here, we're going to pin that, we're going to pin that, and they're going to go in and put 1, 2, 3, probably 4 pins through that. right? And when I say pins, yeah, they're gonna set it and forget it. You're exactly right. And when I say pins, pins are a nice way of saying what? Yeah, screws. Exactly. So what you're saying is the doctor's really going to screw your ankle. So we want to talk about plantar fasciitis because I don't have that on here. So plantar fasciitis, there's a whole slew of treatments for plantar fasciitis. Um, your ice massage probably is one of the best for it, I find. But the thing you have to pay attention with ice massage is going to cause the tissue to contract a little bit. And if you've already got some adhesions down there, ice massage by itself is not going to be your solution. So I like ice massage with a lot of really aggressive kind of cross friction with a knuckle in that plantar fascia. So a lot of times when I'm working on the feet, I kind of make a fist like this, where I have that knuckle out, and I can literally just run down those tendons of the foot and kind of dig at them. You can use two if you've got a tiny hand. I've just got a really big knuckle there, so I can get in and I can kind of dig at it. And I support it with that finger because if you just let it free, every time you're moving, that joint's getting hyperextended, and you don't want that. They make a cool device, and I don't know where my PT bag is. I'll see if I can find it. They make a cool device called a Massage Star. I really, really, really love my Massage Star. That would be one tool that if you ask me if somebody could have it, I would never give it up. It's a 3-pronged star with a flat blade, a really pointed blade, and then kind of a square blade that I can dig into plantar fasciitis with and trigger points. I really, really love it. I use it quite a bit. The best treatment that I have seen thus far for plantar fasciitis out of everything I've encountered has been the, what do you call it? Oh my gosh, I'm drawing a blank. The modality that I taught last semester to you guys. Shockwave, acoustic shockwave. Yeah, little red star. Yep, exactly, Tyler. Yep, you've seen them. Acoustic shockwave is probably the best. Yeah, cortisone treatments. So what's cortisone going to do is cortisone is an anti-inflammatory, so it's going to go in and calm down the inflammation, which will kind of break it apart, right? But when you're dealing with stuff like, when it's stuck down, that acoustic shockwave, I don't know, it's magic. It is really painful for patients. I know Jesus is here. Jesus has seen the acoustic shockwave. He may even have done it to patients because he works for Edwin. And they have acoustic shockwave at least at 2 of their clinics. And acoustic shockwave is just phenomenal for plantar fasciitis. I like if I could have one of those devices, if they weren't, $6,000, I'd probably have one of them because you could probably do cash pay treatments for plantar fasciitis with that and make money all day long. I'm just saying. I find great results with it. But the main thing you want to do with that plantar fascia is get the inflammation calmed down, whether it's cortisone shots or whether it's ice massage, and then dig at it. I've known people that use butter knives. I had a PT once that kept a butter knife in the clinic, and that's what they use to do plantar fasciitis with. Yeah, you would think that. So, well, they're going to put down a little bit. You put down a little bit of lotion, right? A little bit of massage cream or, deep prep or something like that. And then you just use that blade of that butter knife to kind of dig at it. And she swore by it. She also swore that by using the stainless steel, it reduces swelling. But I think that's a Pennsylvania folklore. But that's a big Amish folklore that we have back in Pennsylvania. Is if you get a bump on your head, if you put a stainless steel knife against it, the swelling goes down. Foam roller works. Yep, roller with spikes. I've got the little. Where are my massage balls? I don't know where my massage balls are. I don't know where any of my stuff is. Sad part. I've got little blue massage balls or AccuBalls, I think is what they're called. I use those. Yeah, scraper would work, absolutely. Any of the Graston tools or the Graston-like tools work well. It's just literally getting in there and digging at that fascia and kind of breaking it up. That's the important part. Yeah, close enough. I mean, Graston's just the name. The ones I have, I don't like Graston because Graston are stainless steel. I have a set of carbon fiber ones. They were a little bit more expensive, but stainless steels have pits in them. Even if they're perfectly smooth stainless steel, they have little micro pits in them. And when you're scraping on people's bodies and you're scraping those dead skins, oh my God, I have to look at the name. They're out in my office or out in the living room. I'll find them. I'll send you the name. But the stainless steel ones, as you're scraping, you're getting skin and microfibers or micro pieces of skin in those little pits. And then even if you sanitize them, you still have a little bit of in there, where carbon fiber is just purely smooth. Yeah, gross, right? Didn't think about that. So open and closed pack position. For the ankle, open packed is 10 degrees of plantar flexion, midway between inversion and eversion. If you look at open packed, it's just that resting position as if you're sitting. You know, if I raise my chair, how does my chair go up? That's not how my chair goes up. There's how my chair goes up. If I'm sitting with my feet kind of dangling, right? I've had this chair for years. If I sit with my feet dangling, open pack's kind of position your foot rests in. So that's the position you're going to mobilize the patient in. Closed pack is full locked dorsiflexion. That's the position of stabilization. And then we talk about those capsular patterns, how we know if it's the muscles or whether it's the actual capsule itself. If at the talocrural joint, you have limitations in plantar flexion, greater limitations in plantar flexion than dorsiflexion, it's a capsular pattern. And if you have more limitation in inversion than eversion, it's a capsular pattern, because we all have natural limitations in eversion. And we also usually have a little bit of limitation in dorsiflexion, just because we are predominantly inverters and plantar flexors. It's just the natural way the foot kind of rests. So here's those joint capsule pictures again. And then there's the muscles that kind of overlay that have nothing to do with the joint capsule. So again, if it's not a capsular pattern, if your patient, we're looking back here, the patient has more restriction in dorsiflexion and more restriction in eversion, it's probably musculoskeletal, not capsular. That's kind of the questions they'd ask you about that. Here's full range of motion at the ankle. So dorsiflexion, we have about 20 degrees. Plantar flexion, we have about 50 degrees. Inversion, eversion, so inversion is about 35, eversion is about 15. So you look, we have less than half eversion over inversion. Subtalar inversion and eversion is about 5 degrees. So I just remember that they're flat 5 and don't worry about it. First MTP, extension, we have about 50 to 70 degrees, and flexion, we have 30 to 45. Again, this is where it gets a little weird with the foot, because all of our feet are very different. That's why there's not this hardcore, you know, well, everyone has 50 degrees of toe extension. No, we don't. And the more we go out towards that fifth metatar, or the fifth toe, we actually end up with less and less extension and flexion, just because that's the way the foot works. The main ones you have to know for your boards are these 4 up here: dorsiflexion, plantar flexion, inversion, and eversion. I have yet to see a question on subtalar inversion and eversion. Doesn't mean that they don't exist, but for the most part, they're going to be talking, saying that your patient is limited to 20 degrees of plantar flexion. Is this within normal limits? And your answer would be no. So functional walking. And this is where it gets interesting. If you look at this, for the foot, when you go back here, so our normal plantar flexion is 50. You only need 15 of it to walk. That's pretty impressive, right? I mean, at the foot, we don't need as much motion as we need at the hip and the knee. The big thing comes into play when you're ascending and descending stairs. And again, this is ascending, descending stairs normally. If they're missing this range of motion, it doesn't mean we can't compensate by teaching them to walk backwards or walk sideways downstairs. But this is if the patient wants to walk up and down the stairs normally. So walking on a level surface, you need about 10 degrees of dorsiflexion and anywhere between 50 and 30 of plantar. Ascending stairs, 15 and 30 of dorsa, 15 and 30 of plantar. Descending stairs, you need full dorsiflexion, because you're going to plant down and roll through it, right? So you need that full dorsiflexion, as much as you can get, or as much as the patient has, and then about 40 degrees of plantar flexion for the part that you go down to get the stair. So the next thing we'll talk about is kind of goniometry and manual muscle testing of the ankle. So I'm going to get out of this because I want to talk about a little bit about that before we talk about that tomorrow. So let me get out of my slideshow here. There we are. So I'm back. So this goniometer, the big goniometer, is probably not your best option when it comes to ankle dorsiflexion and plantar flexion, because this can get a little too big for it. A lot of times you want a medium goniometer for ankle movements. What you need to understand is when we get into talking, and when I talk about, I'm going to face the camera because you guys aren't over there, you're over here. I might have to move that camera over there. When you're talking about ankle dorsiflexion and plantar flexion, I talked briefly about this in physics. You're going to start your goniometer like this. So it's going to, actually, let me flip it so we have the movement arm. There we go. A lot of times you're going to look at this and go, oh, well, the patient's got 90 degrees at neutral. No, there's a 0 here. This is 0 for the ankle when we're at kind of a 90-degree angle. So you're going to measure off of that into dorsiflexion. And so a lot of times you'll come here and it'll be like, oh my God, the patient's got 360 degrees of ankle dorsiflexion. I've had students say that before. If the patient has 360 degrees of ankle dorsiflexion, something's wrong, right? Because normal is not that much. So you need to be paying attention that when you're doing this, if you're coming off what your range is, and your range a lot of times is just going to be, you know, that 20 degrees or whatever it is. If you're going to 90 and this goes to 70, your range of motion is only 20 degrees. It's the difference of whatever your range of motions are, right? So if you start at 90 and you plantar flex and the patient goes to 130, that's a 40-degree difference. And we'll talk more about this tomorrow when I actually show you kind of how to measure the ankle and how to measure the manual muscle test of the ankle, right? For manual muscle testing, we'll talk about this again tomorrow when I'm going through it. You will have to know plantar flexion, dorsiflexion, and then inversion, eversion. But I'm going to guarantee something. Those are probably the easiest manual muscle tests you will ever learn. Out of all of the manual muscle tests we do, the ankle and the wrist are the easiest manual muscle tests you're going to do because there's not a ton of alternate positions for them. So it makes it kind of easy. There's just kind of a one position fits all for all of them. It's usually in short seated. That's it for the foot and ankle lecture. Are there any questions?